Welcome, everyone, and thank you for joining us today. The American Society of Transplantation and the Indian Society of Organ Transplantation are proud to present today's joint session on updates in BK virus and CMV treatment. In a moment, I will turn the session over to our moderators, ISOT Council Member Dr. Dinesh Khullar from the Max Super Speciality Hospital in New Delhi, and ISOT Council Member Dr. Pratik Das from the RN Tagore Hospital in Kolkata. Today's first speaker on BK virus will be Dr. Camille Kotton, who is the Clinical Director of Transplant and Immunocompromised Post-Infectious Disease at Massachusetts General Hospital, Associate Professor at Harvard Medical School, and former Chair of the Infectious Disease Community of Practice at AST. Our second speaker today on CMV is Dr. Atul Humar. Dr. Humar is the director of the University of Toronto's Transplant Institute, a professor of medicine at the University of Toronto, and past president of the Canadian Society of Transplantation. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcement. This webinar is being recorded, and the archive will be available on the AST YouTube channel 2 to 3 business days after the live session. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Das, to begin our presentation.
Hello, everyone. Here we are for the listening of from the two stalwart speakers regarding two viral infections, which are very much important to any transplant community. One is a BK virus infection, another is a cytomegalovirus infections. So I think we'll listen initially the elaborated talks, and after that we'll invite or discuss amongst ourselves regarding the questions. So without wasting time, may I request Dr. Camille Kotton to start her presentation.
Wonderful. Well, thank you very much. It's really a pleasure to be with you all. And it's an honor to be here with Dr. Atul Humar to talk about updates in BK virus and CMV treatment. I will be talking about BK virus. I have a few conflicts of interest, and I will be discussing off-label use of diagnostics and therapeutics. So, as you probably know, BK virus causes a significant amount of disease in organ transplant recipients. In about up to 10 to 20% can have issues around premature allograft failure due to BK nephropathy. And screening and monitoring for replication is key. Treatment involves reduction of immunosuppression, and which increases the risk of rejection, and I'll talk a lot more about that. Unfortunately, at this point, we don't have any effective vaccines or antiviral drugs that are approved for either prevention or treatment. And importantly, the last International Transplantation Society guidelines were from 2005. So we were sorely in need of an update. So up to 85% of patients around the time of transplant can have BK viruria. A subset will go on and have significant DNA emia, and then a subset of those will go on and have nephropathy. And it can be somewhat challenging to make the diagnosis. And as you can see in that gray box at the bottom, there are all types of manifestations of BK nephropathy that we see. So I am, and the most recent American Society of Transplantation guidelines are shown there, published in 2019 and done by my colleague and senior author on the new guidelines, Hans Hirsch, as well as Dr. Parmjit Randhawa, who ran the pathology section. So, and those guidelines published by AST are just AST guidelines written by two authors and multiple peer review people, whereas I'd like to announce that we have international consensus guidelines that we did. TTS, the Transplantation Society, asked us to do an update. We got independent funding from Roche Diagnostics. Hans Hirsch and I led this effort together. We started with the AST guidelines and built on those. We invited about 80 international experts, of which just over 50 accepted. And we formed several working groups as listed there, and I'll talk about that in more detail. And then reviewed the literature, did a grade evaluation, and then recommendations. We met because of the pandemic as a hybrid meeting. About half were in person and half were virtual. And I'm very excited to announce that the manuscript has been accepted for publication in Transplantation, and actually just today has moved towards production at the publisher. I'd also like to highlight that we had the good fortune of having two people represent India, and that includes Dr. Sumita Bagchi and Dr. Sanjay Agarwal. So we were really thankful to their input in that they represent the Indian experience, but also represent a significant amount of the world doing organ transplantation. So just to highlight the different TTS regions here, and we had representation from all of these regions. Here's a picture of us, and you can see that many of us were there in person, but numerous people were virtual. And some of them had to be up, especially I think the Australians, up in the middle of the night and whatnot. But we were really thankful and appreciative to everyone's input. So here are the different work groups that we had, and I'll go over the highlights of these updated recommendations from each of them. Again, we used GRADE, which I'm sure many of you are familiar with as far as quality of the evidence. So we looked at quality of evidence and then the strength of the recommendations that we could make. Unfortunately, as many of you know, in transplantation, we don't always have a high quality of evidence, and we can't always make the strongest recommendations. But I think we synthesized the world's literature and also had over 50 experts. So together we were able to make what I think are pretty robust guidelines. Now, just to start with epidemiology and risk factors, and I'm sure many of you are familiar with all of these, I will just highlight that there's not a lot of robust data as far as who the highest risk situation is, other than I will say that people who have BK virus mismatch, where the donor is positive and the recipient is negative by antibody testing, although that is only done in research centers, and we do not recommend that antibody testing be done because there are a lot of quality problems with the antibody testing. So even though that's one of the few strong risk factors, we don't recommend serologic testing. Also, the use of tacrolimus compared with cyclosporin. And for those of us that are old enough to have sort of known the cyclosporin era and now the tacrolimus era, and why are we seeing more BK? Well, it may be due to tacrolimus use. On the other hand, we see somewhat lower rates of rejection. So there's always that price to pay. Future directions, so we basically made recommendations and then we had a lot of future directions. And I just wanted to highlight some of the areas. And I would encourage people, if you have the capacity to do research in any of these areas, these are areas of great interest. So maybe where you'd want to focus research projects or include it in current research projects you might be doing. But basically, if you're doing ABO incompatible living donor kidney transplant, look at BK risk factors and rates in that population. If you're using mTORs, again, examine BK nephropathy in that situation. I don't know that in India you're using tortinovirus. We don't have access to that in the United States, but think about that as a risk factor or marker of the risk for BK nephropathy. And then think about optimizing immunosuppression and what about those who have low neutralizing antibody against donor BK serotypes. That's really highly experimental, not something that would be done clinically per se. And then evaluate the role of BK DNA urea for recurrent DNA anemia and nephropathy after repeat transplantation. So in pathology, and for those pathologists on the call, I would strongly encourage you to look at the details. But basically, the highlights of the pathology group were that we recommend that in the context of detectable DNA anemia from BK, a kidney biopsy be performed when clinically indicated. So a rise in serum creatinine, proteinuria, hematuria. But when we have detectable BK DNAemia and stable renal function, we would only really recommend a kidney biopsy for people who are at high immunologic risk, highly sensitized, et cetera, or high virologic risk. And then there's a recommendation that kidney biopsies not be interpreted on their own, but that they be interpreted in the context of clinical laboratory and virologic data and prior biopsy findings. And then we had a final, there are many recommendations, too long for this call, but we do suggest to not perform a biopsy during the course of resolution of BK DNAemia or nephropathy unless rejection or another kidney disease is a matter of concern and detection would alter management. So no need to do follow-up biopsies if everything seems to be resolving nicely. Future directions include things like standardizing immunohistochemistry protocols, defining clinically actionable thresholds for molecular diagnostics. Right now, unfortunately, we don't have with BK DNAemia, what is called viremia, but technically is the amount of DNA in the bloodstream. We don't have thresholds by which we would say this is definitely nephropathy, et cetera. And then using cell-mediated immunity assays in combination with DNAemia and biopsy findings to optimally adjust immunosuppression. And then further look at non-invasive assays that provide information. And I know there are discussions around things like cell-free DNA, but so far we don't recommend that in the context of BK management. So the diagnostic section had comments on screening. So we do recommend, and this is kind of one of the strongest things, we do recommend regular screening of kidney transplant recipients for BK replication to identify patients for treatment of probable, presumptive, or biopsy-proven BK nephropathy. We recommend screening monthly for the first 9 months, and then every 3 months until 2 years after transplant. In resource-limited settings, we recommend using urine decoy cells or urine cytology, looking at decoy cells as the minimal screening approach. And then if the plasma DNA levels are sort of in the 100 to 10,000 range, we would recommend confirmatory testing within the next 2 to 3 weeks. Like, don't wait too long for that. And then if you are using decoy cells, if you have or if you have urine DNA loads of greater than 10 million, we would recommend reflexing to blood testing to further guide clinical management. There are a lot of issues with urine testing. The numbers can be quite variable, and we thought that there was more robust data on using blood management once you have detectable levels in the urine. And I'm sorry, this is hard to, perhaps a bit hard to see, but this is probably the money slide in that it talks about optimal screening, diagnosis, and management. So basically, people looking at kidney transplant, then they undergo pre-transplant screening with monthly screening until month 9, and then every 3 months until 2 years, or if there's allograft dysfunction, or if a biopsy is otherwise perceived to be needed. And then you kind of go through, do they have detectable DNAemia? Are they high immunologic risk or not? Should you just reduce their immunosuppression? Should you do more if they're high immunologic risk? And then sort of an if-then and kind of repeating through the algorithm. Much of this is modified from the AST 2019 guidelines and similar to that, but this is definitely an important update. So the diagnostics group said that further data are needed before we recommend BK serology of donor or recipient. And that would be similar that we would also not recommend BK testing for DNA urea or DNAemia on the donor at this time. And also, although cell-mediated immunity measurement against BK looks quite interesting. We aren't yet at real-time data for that, but that may be something that comes out within the next several years, both for pre-transplant cell-mediated immunity and post-transplant as well. And then we also had a lot of concern about the risk of BK-associated BK-associated urothelial carcinoma and how to best screen people for that. Most of all, clinicians should be aware of the risk. And if you do have patients who've had high-grade viremia or viuria, you may wish to screen them more closely for these carcinomas. So in treatment, we do first and foremost recommend reducing maintenance immunosuppression as the primary treatment of sustained DNA-emia, and that each transplant center develop an institutional algorithm based on your own routine practice now, but to optimize and standardize the management of immunosuppression in that setting. I will say that, so we have two main ways to reduce immunosuppression, and hopefully this will all be published and available to you soon, and you can think about it in your own context. But so the general management approach is first, confirm that all immunosuppressive drug doses and concentrations are within the institutional target range. You know, is the patient where they should be anyway? Have any errors been made, et cetera, or misunderstandings? And then DNA-emia should be monitored every 2 to 4 weeks until, once you're reduced the immunosuppression, until they have cleared or have a stable, very low level viral load. And for rare patients on the very lowest amount of acceptable immunosuppression, but still who have low level DNA-emia, we suggest follow-up DNA-emia and serum creatinine every 3 months. You know, even if they don't seem to have resolved fully, it's still worth monitoring them. So we have two strategies. One is to reduce the antimetabolite first. So reduce the dose of the antimetabolite by at least 50%. And then a further reduction if you don't see at least a 10-fold reduction in DNA-emia by 4 weeks, or if the patient doesn't clear below the lower limit of detection. And you can actually move to discontinuation of the antimetabolite and tapering of the corticosteroid down to 5 to 10 milligrams per day of prednisone, if appropriate. You may wish to add in prednisone if you're stopping the antimetabolite, just so they're not on calcineurin inhibitor monotherapy, in that we thought that was a higher risk of rejection. And then if you still need further reduction of immunosuppression, we would recommend gradual reduction of the calcineurin inhibitor, heading towards a tacrolimus trough target of 5 or cyclosporin around 100. Again, this needs to be individualized for your center, for the patient, et cetera. The next one is starting with reduction of the calcineurin inhibitor first, initially reducing by 25 to 50% in 1 to 2 steps. We suggest further immunosuppression if we don't see the appropriate decrease by 10-fold by 4 weeks, or if there has not been further clearance below the lower limit of detection. Reduction of the antimetabolite by 50% and tapering of the corticosteroids down to 5 to 10 milligrams per day as needed, or discontinuation of the antimetabolite. So sort of gradual but persistent ongoing reduction of either the antimetabolite or the calcineurin inhibitor. And I think probably many of you are quite familiar with this. Now, this is going to be a bit of a spicy slide because I'll talk about adjunctive therapy and what we recommend, but so there's very little that we recommend for adjunctive therapy. So intravenous immunoglobulin can be used as an adjuvant in kidney transplant recipients with an insufficient response to reduction of immunosuppression in order to try to facilitate viral clearance. The data for that are weak, and it was felt to largely be in the category of expert opinion. IVIG can also be used to prevent acute rejection in those at high immunologic risk when immunosuppression reduction is necessary. Now, based on the available data, we do not recommend using cidofovir or leflunomide or fluoroquinolones or statins. And those recommendations are strong with a fairly high level of evidence. So I know that this has been large-scale practice, but if you actually look critically at the data, which we did in detail before making these relatively strong recommendations, we don't recommend cidofovir, leflunomide, fluoroquinolones, or statins, unfortunately. Pediatrics, the one big difference with pediatrics is that sometimes we see late BK. The recommendation is to do monthly screening until month 9, and then every 3 months through month 36. So somewhat longer rather than just for the first 24 months or 2 years, going to 3 years. And again, the pediatrics group does not recommend adjunctive therapy with leflunomide, cidofovir, or fluoroquinolones. So similar to the adult group. We had a wonderful cost-benefit consensus group, and they do recommend routine screening for BK anemia using the strategies proposed in this guideline, since it is associated with an improvement in clinical outcomes and is cost-effective in kidney transplant recipients. And it's actually important to not decrease the frequency of screening because it reduces the efficacy of screening and can actually increase the overall direct healthcare costs. Anytime we lose a transplanted kidney, it is quite expensive, especially if we have to redo the transplant or have them go on dialysis. So there's real cost benefit to doing this closer screening. Now, there are a lot of questions about retransplantation after BK nephropathy, but we do strongly recommend retransplantation in otherwise eligible patients who lost their prior allograft from BK nephropathy. We suggest that the anemia be fully resolved prior to retransplantation. We do not think that a graft nephrectomy is necessary, and that we do not think that that changes outcomes and does expose the patient to another surgery. And then there's insufficient information to make recommendations on the choice of immunosuppression for a subsequent kidney transplant after BK nephropathy, kidney failure. But we would strongly recommend that these people be monitored closely. So just in summary, we've learned a lot. I think having all of us 55 experts get together and really do a vigorous literature review highlights what we've learned and what we know. It can help to standardize practices across centers and countries and enhance clinical trials. Hopefully, this will cut back on the use of non-effective therapies with significant toxicity like cidofovir and leflunomide and fluoroquinolones outside of clinical trials. It does kind of unfortunately emphasize how much we need to learn and investigate, although I will say there's a lot of work to be done, and I would strongly encourage all of you to think about setting up studies, multi-center studies, etc. And hopefully the guidelines will be published soon. I have a lot of people to thank. As you can see here, these are all the members of the different work groups. I'm especially thankful to my colleague Hans Hirsch, who strongly helped me lead these guidelines, as well as the staff of the Transplantation Society who helped with organizing. And I'm also thankful to Roche Diagnostics for providing the independent funding for this. And here is just a quick glimpse of the abstract that describes our guidelines. And I'm very happy to have questions at the end of this. I will now turn this over to Dr. Atul Humar, who will be talking about CMV.
Well, thank you very much, Dr. Kotton, for an excellent talk, which I'm sure is going to be very, very useful to all those who are attending today. And of course, we'll have the question and answer session. May I request everyone who has joined in to post their questions or any comments in the Q&A section, and we'll take them up to after the talk by Dr. Atul Humar. Well, I think after we've talked about BK virus, which we have been focusing more and more on the last about a little close to 2 decades now, we have been much more familiar with CMV ever since we started doing more and more number of kidney transplants or other transplants as well. It was very often called typically the 40th day fever, and we realized the importance that if we are not able to pick it up at the right time, prevent it, and then treat it subsequently, it can be having very serious consequences to the patient. In contrast to what Dr. Kotton has told us, that there is hardly any treatment worthwhile against BK polyoma nephropathy. Fortunately, we have quite a significant number of weapons against CMV disease. And with that in mind, may I request Dr. Atul Humar to talk about the CMV prevention and treatment, and what is the near future has in store for us. Over to you, Dr. Atul.
Thank you. Thank you so much, Dinesh, and thank you to the AST, and a very special thank you to ISOT for inviting me to this presentation. So these are my conflict of interest and disclosures. And these are some of the new approaches that I will touch on during my talk, including small molecule, CMV, CMI assays, T cells, CMV vaccines, and I'm not going to talk about monoclonal neutralizing antibodies, but those are also being developed for CMV. So CMV is one of the most complex viruses that we see, and it's one of the most common infections in transplant patients. It has a very large genome. It encodes over 170 unique functional proteins. And some of the key ones I've highlighted here are UL54, which encodes the DNA polymerase, UL97, which encodes a viral kinase, and then the UL56/89, which is part of the terminase complex, and I'll talk a little bit more about those later. So just to level set everybody, and of course all the audience is aware of this, is that the risk in solid organ transplant is primarily determined by the donor recipient pre-transplant IgG serostatus, with D+R- being the highest risk, D+R+ being intermediate, and D-R+ being slightly lower risk. We generally should not see CMV in D-R- unless it's acquired exogenously in the community, or through blood products if you're not using either leukodepleted blood products or seronegative blood products. So what happens after transplantation is the virus is initially in a latent stage. It's actually latent in the nucleus here, but just drawn in the cytoplasm, and either in donor or recipient cells, and then it reactivates. The inflammatory cascade that we see in transplant recipients contributes a great deal to reactivation. You get CMV infection, which is detectable viremia in transplant patients, or DNAemia as it's commonly referred to. And then normally what would happen is there would be a brisk immune response, both humoral and adaptive, but primarily the CD4 and CD8 T cell response. And this is blunted by the immunosuppression we give. You get increasing viral load, and then some patients go on to develop CMV disease. And this is typically either a viral syndrome or a tissue invasive disease. In solid organ transplant, the vast majority of what we see in terms of CMV disease is a viral syndrome, which initially typically presents only as really malaise and not feeling well, and then patients develop fever and some laboratory abnormalities. Tissue invasive disease does occur, but is much less common. GI involvement is the most common form of tissue invasive disease, but in liver transplant patients, we may often see hepatitis, and in lung transplant patients, we may often see pneumonitis as well. Now, the important thing about CMV is it also has a number of indirect effects in organ transplant recipients, and these are mediated by the immunosuppressive effects of viral infection, but also the pro-inflammatory effects of the virus, and especially due to viral reactivation and replication within the graft triggers a pro-inflammatory response, and this can result in alloreactivity and both acute and chronic allograft dysfunction. So there's two strategies to prevent CMV. The first is universal prophylaxis, where you would start antiviral prophylaxis within the first few days post-transplant and continue for a period of time, 3 to 6 months typically. The second is preemptive therapy, where you do frequent monitoring and then you treat low-level viremia to prevent CMV disease. And we know that prophylaxis works. There's many trials that show that prophylaxis work. But the most commonly used drug is valganciclovir. And there's data years ago from the IMPACT trial that showed that in higher risk kidney patients, so the D+ R- kidney patients, valganciclovir extended out to 6 months was better than valganciclovir given for 3 months for those patients. So you can see the disease rate here in the IMPACT study was 36% versus 16%. There is a cost that you pay in terms of drug toxicity. So there are higher rates of leukopenia the longer you give valganciclovir for. Now, the other very commonly used strategy is this so-called mini dosing. And I'm not going to go through the mini dosing data, but I'll just summarize it, is that one is what we often call mini dosing is actually true dosing if you really calculate the GFR in the average kidney transplant recipient. However, even if you do true mini dosing where you're calculating the GFR and giving slightly lower dose, it probably seems to work in the average kidney transplant recipient, especially if there are positive kidney transplant recipient. However, it should, I think, be avoided in the higher risk transplant settings because it is a risk factor for resistance. Now, the other commonly used strategy is a preemptive strategy. So here you do a test, and it's typically a viral load assay, and you would do it weekly for the first 3 months or so. And you pick up early viremia or DNAemia and treat that to prevent CMV disease. And this strategy actually works quite well if it's done properly. And this is a recently published study in liver transplant patients that compared preemptive therapy versus antiviral prophylaxis in D+ R- livers. And they had about 100 patients in each arm. And the incidence of CMV disease was actually slightly lower in the preemptive therapy strategy. So I think the takeaway from this is that both strategies are reasonable, but with the preemptive strategy, you really have to stick with a very careful monitoring and looking at the results and starting treatment for positive results. Now, some of the newer things that have popped up recently that I'll talk about. The first is using cell-mediated immunity assays, and these have variable availability depending on the country that you live in. In Canada, these are primarily still used as research assays. The way most of these assays work is you take the patient's blood and you use that, you stimulate it with various peptides from CMV, and this results in a T cell response, which then produces cytokines, and then you can measure these cytokines, and it's typically interferon gamma that you can measure, and you can measure this by an ELISA, so for example, with the quantiferon assay, or you can do an ELISpot assay, or you can measure it with flow cytometry. And again, depending on where you live, you'll have different availability of these assays. Now, this is where such an assay might be used. So this was a recent randomized controlled trial in R+ kidney transplant recipients, where they compared 3 months of prophylaxis with immunoguided prevention strategy. So what they did was the quantiferon assay at day 30, 45, and 60, and they stopped the prophylaxis if the quantiferon was positive. And so what this allowed was early discontinuation of prophylaxis. So you can see that the average duration of prophylaxis was much lower in the immunoguided group. The neutropenia was much lower, but the CMV disease rate and the viremia rate was very similar in the two groups. Now, what about treatment? Well, the standard treatment would be either oral or IV ganciclovir, and almost always you can use oral valganciclovir. And the Victor study, which was published many years ago, showed that the two were quite equivalent. Where would you choose IV? I think for severe disease, very high viral loads, or if there's concern about absorption, we would typically start with IV and then transition to oral therapy. Monitor the viral load weekly and a CBC and creatinine to assess for toxicity with the CBC and to dose adjust. Treat until negative, although if you're using an ultrasensitive assay, you may not get completely negative. And then post-treatment, you can either monitor, typically virologic monitoring, or some people might give secondary prophylaxis to higher risk patients, such as 1 to 3 months of secondary prophylaxis. And this is the Victor study that I alluded to that compared oral versus IV therapy, randomized trial, and this was done many, many years ago, and this shows the virological response rates in the two arms are almost completely identical, supporting the use of oral therapy in most instances. Now, this is the mechanism of action of the antivirals. This is a little bit of a complex slide, but if you look at the ganciclovir, here it's phosphorylated by UL97 kinase, and then it's triphosphorylated by cellular enzymes, and it inhibits the DNA polymerase, which is encoded by UL54 by binding to the DNTP binding site. So you can see that if you get a mutation in UL97, so that doesn't phosphorylate ganciclovir, or if you get a mutation in UL54 at the DNTP binding site, then the virus can become resistant to ganciclovir. Foscarnet here on the left has a different mechanism of action. It does not require phosphorylation. It directly binds to the UL54 and inhibits it at a different binding site, though, so something called the pyrophosphate binding site. So the two new drugs on the block, the first is letermovir. And during viral replication, CMV produces these long concatameric strands of genomic DNA. And these require cleavage prior to packaging. And this cleavage is done by a protein complex called the terminase complex, which is about 4 or 5 different proteins, but the main ones are shown here, UL56, UL51, and UL89. And letermovir primarily inhibits the UL56 portion of the terminase complex. And this is the pivotal trial in solid organ transplant patients that was recently published in JAMA, and it looked at 6 months of letermovir, and the dose is 480 milligrams per day, versus 6 months of valganciclovir in D plus R minus kidney patients, a large trial, so 600 patients. You do have to use acyclovir in the letermovir arm if you want to prevent herpes simplex and varicella zoster, because unlike valganciclovir, letermovir does not have activity against those viruses. This was the results of the study. So the disease rates at 1 year were essentially identical. So it was 10.4% in the letermovir arm and 11.8% in the valganciclovir arm, so almost identical. The main difference that was observed was the toxicity. So letermovir does not have the leukopenia or neutropenia toxicity associated with it. So you can see that the event rate was significantly higher in the valganciclovir arm versus the letermovir arm. Now, the other drug I want to discuss is maribavir. So this has recently been approved for refractory and resistant CMV, and this is how you define it. So refractory means you have an increasing or persistent viral load after at least 2 weeks of adequate antiviral therapy and failure to improve signs and symptoms. And a portion of those have resistant virus, and that's a genetic mutation that decreases susceptibility to one or more drugs. The risk factors are D plus R minus, increased immunosuppression, and prolonged exposure to especially low-dose antivirals. And as I know, India is starting to do lots and lots more of lung transplants, and you're gonna, I think, see more resistant viruses, as that's a very high-risk population. So maribavir works by inhibiting the UL97 protein kinase. So if you remember, this is the protein kinase that phosphorylates ganciclovir, but in the virus, it actually has another function. It's involved in viral encapsulation and nuclear egress of viral particles. So when you inhibit UL97, you prevent this nuclear egress. It does not affect the UL54 DNA polymerase. It's not myelosuppressive or nephrotoxic. The main side effect is this taste disturbance or dysgeusia. And this is the pivotal trial that was published now a couple of years ago. And it looked at patients with refractory or resistant solid organ and stem cell and randomized them to maribavir 400 BID for 8 weeks versus investigator-assigned treatment. And this was typically a higher dose IV ganciclovir or foscarnet in most cases. And it was 8 weeks of treatment, although you were allowed a maribavir rescue in the IAT arm. And this was the results of the trial. So at week 8, which was the primary endpoint, it was 55% clearance in the maribavir arm versus a 23% clearance in the IAT arm. And then the drugs were stopped at this point, and you can see there is a relapse rate after that. Now, one of the issues with maribavir, and actually any time you treat refractory resistant CMV, is the emergence of resistance mutations. And maribavir resistance maps to UL97, just like ganciclovir resistance does. And you can see that this is a codon map of UL97 showing the common resistance mutations. So in red are the ganciclovir resistance mutations, and in blue are the common maribavir resistance mutations. And you can expect a resistance, if you're treating one of these patients, to emerge in about 25% or so of patients. There are a few mutations that are cross-resistant, so that confer resistance to both maribavir and ganciclovir, and the C480F is kind of the most common one, which confers high-level resistance to maribavir and lowish level resistance to ganciclovir. Now, two other things I'll just briefly mention. One is adoptive T-cell therapy, and the other is vaccines. So adoptive T-cell therapy involves taking PBMCs from a donor, either third party or autologous, separating out the virus-specific T cells, usually some kind of purification, and then infusion into the recipient, where they should control viral infection. There's actually many studies that show some benefit, but there are a lot of challenges to this, and this has not been widely adopted. There's difficulties in manufacturing. You can use, as I said, either a third party versus autologous. I think a third party allogeneic product is more attractive. It is very costly. There are time constraints. It is for a very niche population, so refractory resistant. And really, as new small molecule therapies have emerged, this increases the challenges of adoption. It may be that a multivirus T-cell product might be better in terms of commercialization, and there is one, at least one, that's being evaluated. It's called Posoleucel, which may be attractive, especially for stem cell transplant recipients, because it covers all these viruses. But you can see it also has anti-BK T cells within it, so it may prove to be attractive for that. And the other thing I'll just briefly mention in one slide is CMV vaccines. And a lot of people ask me about vaccines and why we don't have a vaccine yet. So there are a lot of challenges to developing a CMV vaccine, which I'm not going to get into, but these studies have been going on for 30 plus years now. And as you can see, there's different approaches. So there's protein vaccines, DNA vaccines, vector vaccines, and mRNA vaccines. Many of these vaccines have failed. There are sort of two that are currently in clinical trials, and there's a few that are almost in trials. One is a vector vaccine, which is the City of Hope vaccine, which is currently starting a liver transplant trial. And Moderna has developed an mRNA vaccine, which is currently in a liver trial and possibly starting a kidney trial as well. So I'll summarize with, I think it's a pretty exciting time to be in the CMV field. As Dinesh mentioned, we finally have big randomized trials and lots of data. There's multiple diagnostic therapeutics and preventive strategies being developed, and these really promise to change the way we deal with CMV. And years ago, Bob Rubin coined the term that CMV was the troll of transplantation. This is a troll that hides under a bridge and eats animals that pass by. And I think we're getting much closer to kind of finally defeating this troll of transplantation. So thank you very much. And we'll turn it over to the moderators.
Well, thank you very much, Atul. That was indeed an excellent talk and mesmerizing. So a lot of new things, and you give us hope that yes, there are many new upcoming drugs, which hopefully will not allow our confidence to get shattered as far as the treatment of CMV via its resistance to various drugs is concerned. And thankfully, at least in our country, India, we haven't come across a rampant resistance to ganciclovir or valganciclovir. But I do understand the caution is going to be when we start doing more and more number of lung transplants. So before we move on, a few questions for you, Atul. So one of the challenging things is the concomitant rejection and CMV disease. How do you really treat that entity?
Yeah, it's an excellent question. So I think the good thing with CMV is because we have potent antivirals, I think you can treat both those entities concurrently. I don't think you should try to sacrifice the graft because you have CMV. So it's important in that setting to use an appropriate dose of valganciclovir or ganciclovir and concurrently treat the rejection. The exception is if you have resistant virus or if you have very, very severe CMV, like CMV pneumonitis or severe tissue invasive disease, then you need to be careful about augmenting immunosuppression in those settings.
And any role of CMV immunoglobulins at this point, if you really have to hit the rejection bit really hard, yeah?
Yeah, it's a good question. I mean, the data with using immunoglobulin for CMV in any setting is very poor. But I think that's actually a reasonable setting to use it in if you're going to use it in, because there's very little downside, and it may help you in terms of immunological control of a rejection episode.
Yeah, and another diagnostic dilemma at times is the tissue invasive CMV, and at times I'm sure every one of us misses that because we so many times would rely on the CMV DNA and probably miss out on any comments on the necessity for more intensive diagnostic tools to find out tissue invasive CMV?
Yeah, it's an excellent question. I mean, most of us have moved away from invasive testing, so because of the very sensitive viral load detection assays. So I think if the patient is viremic and they have symptoms like they probably have tissue invasive disease, but you don't necessarily need to make that diagnosis. You can treat them and look at the clinical response. The exception is there are cases of tissue invasive disease where there's no detectable DNA-emia, and gastrointestinal disease is a classic example of that sometimes patients will have reasonably significant gastrointestinal disease but have undetectable viral loads, and so there you do need to do more invasive testing to make a diagnosis. And the other time is retinitis as well, where they may have pretty significant retinitis, but an undetectable viral load. So you need to be careful in those settings.
Atul, a very important thing is we are all the time as nephrologists very energetic when it comes to prophylaxis with cotrimoxazole is concerned whenever we have given our patients high-dose steroids. I mean, I'm talking about a patient with lupus nephritis having been given all those heavy immunosuppressive agents. Would you recommend a routine prophylaxis with valganciclovir in those patients as well, the way we do it for our transplant patients?
We haven't normally done that, and people have asked me that before, whether those patients should be given prophylaxis. And I have actually seen CMV disease in those patients, to be honest with you. So there's not great data to support doing that. Another approach in those patients, if you're really worried, is to monitor their viral loads. And, it doesn't need to be weekly. It could be every couple of weeks. You could monitor their viral loads and use more of a preemptive approach rather than give them prophylaxis. So
I think we've also seen that in critically ill patients as well. I mean, in apparently healthy till then patients, I'm talking about so-called immunocompetent who for some reason land up in the intensive care units. And if you try to screen, they may also be found to be positive for
that's an excellent point. Like what happens is anytime there's a significant inflammatory response, it promotes CMV reactivation. Now, what does that mean in the critically ill patients? It's hard to know. There actually have been studies done of looking at antiviral prophylaxis in those patients that, as far as I can see, have not yet clearly shown any benefit. But, it's an interesting question for sure. It does reactivate. You're absolutely right. It does reactivate in those patients. What it means and what you do about it, I'm not entirely sure outside of the transplant setting.
And before I hand it over to my friend Dr. Pratik Das, a few questions about the resistance. I mean, thankfully, as I said earlier, we don't get to see a rampant resistance against valganciclovir, at least in our country. And in fact, to tell you the truth, we don't have facilities for genetic mutation testing. We don't have facilities for UL 97, 54, or 89. So do you think we are missing out on these cases? I mean, but let me give you my viewpoint. Most of the times when we diagnose a given patient as having a CMV disease and we treat with ganciclovir intravenous to begin with and then follow it up with valganciclovir, we have had excellent results. So I don't think we are missing out on resistant this thing. And that's first part of the question. And if, yes, indeed, it is there and we are missing out on a lot of questions, how would you advocate the use of the toxic drugs like forcasnet? We have never used forcasnet that often. Cidofovir, again, I mean, because thankfully, as I said, we are very happy with what valganciclovir can do for us. So your comments on that?
Yeah. I think, normally if you have a good clinical and virologic response to valganciclovir or IV ganciclovir, it's unlikely you have a clinically significant resistance there. So we would normally not test for resistance in those settings. So really only if for some reason they're not responding to ganciclovir. And in that case, there's two reasons. Either they're over immunosuppressed, and that's why they're not responding, or they actually have a resistance mutation and they're not responding. And in that setting, it actually does help to have resistance testing available, although, I'll tell you, even in Canada, our turnaround time for that is about 3 weeks. So we have to make all the clinical decisions beforehand. I personally have also started moving away from using, for resistant virus, from using foscarnet for kidney transplant recipients, especially, just because of the nephrotoxicity issue. And there, we're using more maribavir now as first line for resistant, for true resistance or refractory to ganciclovir in that setting.
So for the reason which I had alluded to earlier, I'm going to talk less about maribavir because we are probably going to have a lesser need for that in our country at least.
Yeah.
But the hope is in the form of letermovir, you see, because so many times we struggle to give the appropriate dose of valganciclovir in leukopenic patients. And from what I hear, and we were quite excited when we came across that JAMA article in June, that there's hope for even the leukopenic patients. So would you recommend the routine use of letermovir in those patients who have CMV disease and are leukopenic to begin with?
Yeah, so I wouldn't recommend letermovir use routinely for treatment. The treatment data with letermovir is much less robust. There's some data suggesting if the viral load's very, very low, like less than 1,000, it's probably reasonable, but with higher viral loads, there's probably a pretty high failure rate. But we need more treatment, so we need more data. So where letermovir could be used is prophylaxis. So in these patients you talk about that have a lot of leukopenia while on valganciclovir prophylaxis, transitioning them to letermovir instead, or to a preemptive strategy, either one of those would be okay. I mean, the challenge we face in Canada is both with maribavir and letermovir is really the cost issue for us. And I think that might be a similar challenge you might face in India. So that kind of limits us to the use of these drugs. There are programs in the US though that are transitioning all their patients to letermovir prophylaxis. But I don't foresee that ever happening in Canada.
Thank you very much. Sorry, Dr. Kotton, please go ahead.
I actually just want to say, I don't think that it's feasible to do that in the United States. It's about $40,000 US for 6 months of letermovir. There's discussion as to whether they will do that, but it's not economically feasible. But I know some people are thinking about it.
Some people, yeah.
But
I don't. Yeah.
Well, thank you very much, Atul. That was excellent, amazing. And I think over to you, Dr. Pratik. And I was really amazed to see how quickly Dr. Kotton is answering most of the queries which have been posted, the questions which have been posted on the Q&A section. Thank you very much. And I think half the job has already been done, the quickness with which he's been doing that. Over to you, Pratik.
Yes, I have also seen that, but for everyone else, let's listen for her. Unfortunately, we don't have any antiviral drugs for this BK virus infection. So everybody is concerned about this reducing immunosuppression. So a bit detail about the immunosuppression, suppose in terms of using an mTOR inhibitors, or here the difference between a CNI versus a belatacept regime. And thirdly, if you are on a steroid-free regime, then will you stop one drug and maintain the patient on the one drug? So these things we need to hear from you.
Okay, so we would not recommend, that's what I was saying, with the reduction of immunosuppression, whether you start with anti-metabolite reduction or calcineurin inhibitor reduction, if the patient is on a steroid-free regimen and you completely stop either the calcineurin inhibitor or the anti-metabolite, we would recommend keeping them on low-dose steroids, usually prednisone 5 to 10 milligrams a day, so that they're not on single agent, either anti-metabolite or calcineurin inhibitor. So that's actually one of the steps in those guidelines. Sorry, I know I was both going very fast and then I wasn't able to answer everybody's questions. I am so excited about these guidelines coming out, and I hope that you will all be able to see them and read them. If you follow me on X, I will certainly be tweeting about them. So yeah, hopefully we'll have those out soon. For belatacept, unfortunately, we don't have robust data on what to do. And I copied that into the Q&A, but we don't really have robust data on what to do in that setting. I will say that we know that there's an issue with belatacept and new viral infections, whether it be CMV, EBV, for which there's a black box warning, or potentially BK. So if you have refractory viral infection on belatacept, I strongly recommend that you stop the belatacept. My transplant group knows this. They get these emails all the time from me. Stop the Bela at least for 6 to 8 weeks. Get them on some other regimen temporarily. It might be mTOR, might be calcineurin inhibitor. Clear the virus, and then you can put them back on Bela. But unfortunately, Bela and viruses are not a great combination. But we don't have in writing guidelines, we have to use published data, robust data, et cetera. So we aren't able to give like strong formal guidance on that.
Okay, thank you very much. So another thing that was asked in the box also regarding there is some changes in the innate immunity of the recipient, and the newer drugs that we know that leflunomide is not going to work, quinolones is off, CWV we are not using in the kidney transplant patients. But what about this? This is the newer ones, like anyone has asked about this T-cell treatment. This is adapted immunity. This is a T-cell treatment for this BK virus infection.
Yeah, there's a lot of questions about T-cell treatment. So far, that doesn't look like anything that we would be recommending in the near future. Unfortunately, the AlloVir trials, you may wish to just do a quick Google search. It doesn't look like those will necessarily be proceeding, unfortunately, sort of off the shelf T-cell therapies. Honestly, for many patients, what we really need to do is expert management of immunosuppression, and that will take care of the vast majority of patients. People are reaching for leflunomide, cidofovir, T-cells, all kinds of expensive and challenging things. The vast majority can be managed through artful and expert immunosuppression management.
So do you use these immunoglobulins, and at which dose and how frequently you use these immunoglobulins for the refractory viremia?
Yeah, for BK, you mean, not for...
Yeah, BK, yeah.
It could actually be for either, I think. It could be for BK or CMV. Yeah. So I don't think that we have data to strongly suggest the use. We do recommend it in, say, perhaps our more challenging cases of BK, especially when you're concerned about reducing the risk of rejection. I would say the same thing for CMV. The times that I give CMV immunoglobulin are when I have resistant, refractory, or really horrible CMV. So it's very rare that I give CMV immunoglobulin or that I give, which CMV immunoglobulin is just IVIG that's enriched for highly CMV positive donors. But so I rarely would give it for either BK or CMV, but just those extenuating circumstances. I hope that helps.
Okay, thank you very much for this great talk. We have been enlightened by both of you. So thank you very much.
Just a couple of questions which are there in the chat box as well. Regarding that's for BK again to Dr. Kotton regarding the importance of monitoring BK viruria. So would you give any importance to that first in the pre-transplant period for the while screening the donor, and then subsequently monitoring in the post-transplant period? Would you give any importance to BK viruria?
Yes, so we don't recommend checking the donor for viruria, for serology, or anything. There's no data to show that that is effective. Over 85% of people have BK infection, and these are predominantly, reactivation infections. They can be from the donor as well, but we don't have any data to show that testing the donor is either cost-effective or clinically useful. So then we do, depending on what you can do in your own center, if you can test urine for decoy cells, if you can test for urine for BK DNA urea, you can do that. If you can check for DNA emia, do that. I think the most important thing is do something, screen accordingly, and then reflex to blood testing if you're doing urine testing.
So there was another very interesting question for you, Atul, from Neeraj Sinha. And as you had anticipated, the lung people are going to experience some kind of resistance. So his question is regarding the role of cell-free DNA when it comes to monitoring. So you've already answered that, but for the sake of the audience, I think it'll be very important if you can elaborate.
Yeah, it's actually a very interesting question. So, the use of cell-free DNA as a diagnostic marker for rejection or inflammation in the graft is becoming more common depending on where you live. But basically, as there's inflammation and rejection in the graft, it'll release the cell-free DNA into the bloodstream. But what will also happen concurrent with that is there's local viral replication and reactivation occurring. And so there is a correlation between detection of cell-free DNA and detection of CMV, and it's probably especially stronger for lung transplantation. So, it's an interesting correlation. What do you do with it? I think you just have to continue the same treatment strategies that you would normally do in a lung transplant recipient. So if you detect DNA emia at a given threshold, you should generally treat that, I think. And what that threshold is, of course, everybody's using a different threshold, but we would use typically 1,000 IU per ml as a treatment threshold.
So another interesting question by Ian Liu. What do you think of CMV inclusions found on random clonic or gastric biopsies in vintage transplant patients without any CMV symptoms? And I presume the patient is not having detectable CMV viremia. So what would you do? And this patient was undergoing investigations from the cancer point of view. Would you still treat this CMV invasive disease? And
yeah, low. Yeah, it's a good question. I mean, we don't. It does occur from time to time, and if you do see CMV inclusions, it suggests there's a significant viral replication and pathological response there. So in the past, that was always diagnostic of tissue invasive CMV disease. So we would tend to treat those. I mean, typically you can just treat with oral therapy. And because there's no peripheral viremia, the question is always, how long do you treat those patients for? But sort of in the 3 to 4 week range would probably be a reasonable approach, especially if it's in the allograft, because if there's viral inclusions in the allograft, then there's probably going to be some damage either in the short term or long term induced by that viral replication in that graft.
So I think this discussion can go on and on. It's just the time which stops us, it prohibits us from going any further. I have thoroughly enjoyed, and I would sincerely thank the organizers for this wonderful opportunity. And thank you very much on behalf of everyone, those who have attended today, to our speakers, both Dr. Kotton and Dr. Atul Humar, for the excellent talks and the subsequent clarifying the doubts in everyone's mind. Thank you very much. And I'm sure everyone who had joined has been immensely helped by their huge expertise and knowledge about the subjects. Thank you very much once again.
Thank you,
So
Dr. Khullar.
final words from Dr. Pratik. And Brian, over to you.
Yes, I agree. Every point we have thoroughly enjoyed, learned a lot. I hope the audiences have also learned from this first-hand experiences from this expert.
Thank you. AST would like to thank our partners at the Indian Society of Organ Transplantation, our great ISOT and AST panelists, and all of our attendees for today's session. Please look for an email from Zoom in about a week directing you to a copy of the recording, free and on demand. Finally, please remember to complete the evaluation survey in Zoom to help us keep our content current and engaging. Thank you all again for today's fantastic session.